Good morning, Chicago. I'm Dr. Allison Arwady, Commissioner at the Chicago Department of Public Health. Thank you for joining us. As always, this is your chance to get your COVID questions answered. And now that we're in stage 5, it's also an opportunity for us to talk a little bit more broadly about some of the ways COVID has impacted Chicago in less direct ways, some other ways that the Chicago Department of Public Health is continuing to work and prepare, and continue to have the opportunity to answer your questions. So we have a special guest with us today. This is Christopher Shields. He is an assistant commissioner at the Chicago Department of Public Health, and he is in charge of our public health emergency preparedness program. And we sometimes call it FEP. And the Public Health Emergency Preparedness Program is one of those programs that people don't think that much about until they need it. And certainly during this last year of COVID, there's been a ton of need. We have absolutely depended on this team and the work that has been done. So I'm really pleased to have you here today.
Thank you.
Today is Tuesday, June 22nd. We'll look at the dashboard. As always, we'll have opportunities that you can put questions in. So we'll talk a little bit with Christopher. You can start putting your questions directly into the box below. You can also use the hashtag AskDrArwady on Facebook or Twitter. But let's go ahead and dive in. So welcome. Go ahead and tell folks a little bit about your role, your program, and then some of what you've all been doing before and then during COVID.
Yeah, absolutely. So our program is based on emergency preparedness planning for scaled events for large public health impacts. The program at the national level was built right after the attacks in 9/11 in 2001, and then realistically it got a forward momentum push in October and November of that year, which was the first anthrax attack. So the original basis of the program was preparing large urban areas to have a system in place, plans, policies, procedures, infrastructure, capabilities to immediately stand up a forward-facing operation. And at that time we were looking at anthrax, which is a Category A threat agent. And then over the years the program has evolved significantly over time. We moved from the 2001 era to 2005 with Hurricane Katrina. And that was an all-of-nations event, more of a large population movement, a large mass care event. So our program shifted with that as well to add on capabilities for what does shelter housing look like? How do we do congregate care? Do we have the infrastructure in place that we can immediately start just minor medical assistance to support the larger healthcare system? 2009 brought us the H1N1 pandemic. So again, our program widened our view to move on to our ability to rapidly move vaccine into not only the healthcare infrastructure, but bring it down to the community. So we brought on different systems, our ability to bring a vaccine out of its refrigerated or frozen state and keep it out in the community for up to 72 hours without being any requirement of power. So the idea there is we weren't landlocked. We could actually bring vaccine all the way down to an end user without worrying about the requirements of power. 2014 brought us Ebola. And so that really was not the first time, but the first significant push for the city of Chicago to really engage with the quarantine station at O'Hare International Airport. What does it look like to do inbound screening? What does it look like to rule a potential ill client and determine the appropriate hospital for that individual to go to? So we learned a whole bunch about that, really expanded up the program. 2019, we were in the middle of a mayoral transition. Obviously, Commissioner Arwady was coming on board, and we were getting ready for an exercise called Crimson Contagion, which was an all-of-nations pandemic influenza exercise. And that kind of helped us formalize some of our planning documents, not only the policies and procedures, which you need to physically do it, but the methodology on how a plan is built. And at that time, we kind of did a little turn in space. We decided to, instead of X, Y, Z in a process, we said, here are planning considerations if these variables are in place, to give a decision tree or courses of action for the commissioner and the mayor's office to go, okay, this is where we are at this point in time, so we need to be doing these planning considerations. And how fortuitous that Crimson Contagion exercise actually prepared the city to immediately step off in December of 2019 when we had an inkling of this new disease in Asia on where do we need to be, where do we need to start positioning ourselves, what resources do we have immediately to put to bear, get our hospitals engaged and up to speed. So in our downtime, we do a lot of pre-planning, making sure that our infrastructure teams are trained to respond, that we have the appropriate materials on hand and are not waiting for supply chain to initiate a response.
Yeah, perfect. So you get the sense that there is a lot happening, even before our response began. And I think, you can go ahead and start putting questions in if you've got them about our emergency preparedness. But let's actually talk a little bit about crimson contagion, if you don't mind. So every year we do large exercises and we think about how to make sure the healthcare system is prepared, the public health system is prepared for whatever might come. Do you want to just talk a little bit about some of what that looked like?
Right. It was an all-of-nations exercise, and the Department of Health and Human Services allowed jurisdictions to kind of pick and choose what elements of this event they wanted to exercise and try out. The city of Chicago, we were a co-planner in this event, and we had just finalized our pandemic influenza plan. So we really wanted to go, we have a new mayor, we have a new commissioner, lots of new aldermen, go down to the minutia of what does it take to get a public health declaration in the city all the way up to the federal government so we can initiate fund streams, so we can initiate the response. Over 5 days, we exercised not only with our infrastructure departments, but we exercised with the entire healthcare super system here in the city of Chicago. 35 hospitals, 29 comprehensive ERs, 9,000 acute care beds. What does it look like in a medical surge event? What is your capacity, not only by regulation, your capacity to surge up, but what can you actually do? And if you needed to expand, what can we as the city help provide you to allow you to expand the breadth?
Yeah.
We wrote that plan based on 17 planning assumptions. So we exercised against 17 planning assumptions, everything from what does continuity of government look like, what does mass care look like, what does quarantine look like, unfortunately, what does fatality management look like. When we turned the door to the COVID response, all 16 of our planning assumptions up to vaccine, we had just exercised the year before.
Yeah. And so what that really meant was that we had, just the prior year, soup to nuts, really pulled partners together, said, what would it look like in a pandemic if we had to close schools and potentially make sure children and families were getting fed? What would it look like to have to stand up, a large vaccination site? Who needs to be in the room? What do the healthcare partners need to know? What would PPE resource requests look like? Really very practical work. I remember standing up one of the mobile morgues, in the parking lot, and really making sure that we had done whatever we could to be in place. And so where you think all the way back, to as the pandemic really took off, where do you think Chicago was different, for better or for worse, than other places around the country in terms of some of that preparedness work?
I think in the grand scheme of things, not only my tenure here with the city of Chicago, but my predecessors had built the program on capability and capability sustainment. So not only was it acquisition of physical materials like the mobile morgues or the ventilators or even the PPE cache that was in place, but it was how do I sustain that capability over time, not get too big. Mm-hmm. Some jurisdictions, I think, fell off that they couldn't sustain that caching capability. They didn't have the infrastructure or systems in place to ensure that a mask that I purchased in 2014 is still valid in 2016. So we did a lot of infrastructure investments, refrigeration and freezer systems, our mobile capabilities, all these things to ensure that any product that was purchased wasn't a waste of the federal tax dollar. We could immediately use that. And I think that truly set us apart, not only from jurisdictions that are comparable to us, but states as a whole across the U.S.
Yeah, that's right. And so, you know, where you think back to a lot of that struggle, particularly for PPE at the beginning, you know, talk to us a little bit about what your program was doing at that point, and you know how we switched some of our posture there.
So I think one of the key pieces is the distinction between medical personal protective equipment and just traditional protective equipment. So our program had been pre-positioning medical supplies within our hospitals just in case an exotic disease or something out of the ordinary would come to bear at their institution. They don't use the supplies, but they're part of our infrastructure, quality assurance and quality control. So our teams are always in there validating the quantity of material. And it was based more or less on the bed capacity, the number of clinicians working in the institution with a factorial number. And we did that with pharmaceuticals and we did that with PPE. When this event kicked off, we immediately said, if you need to use the cached inventory of PPE, go ahead and do it. You just need to tell us how much you're consuming and what are you consuming. We also said, this is your time. Structure your supply chain now. If you're expecting a delivery on Friday or expecting a delivery at the end of the month, see if your supplier can move your delivery up so that you have material on hand. And if you're a small institution, we can help with storage space because you're all familiar with our regulatory. So we could help you in the storage sites. We kind of pre-positioned the hospitals and the healthcare enterprise as a whole just to be thinking forward of what are we going to need? And because of the Ebola response, we had the whole paradigm from one side to the other side. Do I need complete isolation capability? Do I need just general coverage capability? What's the difference on my staff in the hospital? Does the clinical services need something different than food services or your utility group or your cleaning services? What does that look like in an institution? And some serious critical thinking happened. Our hospital preparedness side of our program had several meetings with not only the C-suites, which is your executive suite, but the people that are similar to what we do, the preparedness planners, that's the institutions, to say, where are we postured for this? And then it was more of, now tell us, what does it look like? So turning back to Allison, to your epi division to say, what does this look like worldwide? What does this look like close to us, the countries bordering us? What does this look like in the United States?
Yeah, that's right. And I think, the fact that we did have, millions of masks that had been appropriately stored and were ready to go. And I mean, you were sending out, what, 40 to 50 tractor trailer loads a day of this, in that early stage where there was such a struggle for PPE, and we had the inventory management, and we had already the communication with healthcare in terms of what some of that would look like. And I think for me, this is a big expense, right? Like making sure that we are having structures in place, but then when we needed it, we could turn it on in a way that I think very few other settings could. And even at the federal level, there was not the stockpiling, I think, to really back up what had been done at the local level. And one of the lessons I think there is around when supply chains get disrupted, around the world, what does it look like to make sure, that there's enough nationally? But I do think it was a major thing.
I think the one piece to that, and my predecessor kind of set this up, we wanted to be, as a city, have enough inventory in place to immediately go to bat, immediately get into the response mode and not be waiting for either a delivery from our manufacturer contractors or a delivery from the federal government. We wanted to have that on-hand capability for the immediate response, and that truly set us apart from a majority of the jurisdictions because we weren't waiting for the traditional supply chain to feed us on-hand inventory. We already had it in our possession.
Right. All right. So we're getting some comments in. Just wondering a little bit about sort of how prepared are we now, or kind of what does this look like as we move forward. And I think one thing here was there were things that we had plans for, and there were things that we. Frankly, the scale of this, I think, was so different that there were some things that your program really took a lead on that we were having to, build on expertise that we had, but were brand new for us. So, I mean, one of those obviously was the work at McCormick, and I think this possibility that we were actually going to overwhelm the healthcare system was something that certainly we had talked about in a theoretical way in our planning, but more when we had been thinking these mass care, it had been more in a large, flooding or earthquake or something where we're providing lower level care. This idea of really needing to significantly increase the hospital level capacity was not something that I think we had as many plans for. Do you want to talk just a little bit about that?
Yeah, absolutely. And I think for those of you that receive medical care in the city of Chicago, we have some fantastic institutions. And because of that, people come from all over, not only the state of Illinois, but Wisconsin, Indiana, and Michigan to come and use services. When we got into the response where we were having the high infectivity rate, you were having really pretty severe respiratory complications, we were receiving clients into our infrastructure that we had theoretically planned for, but not by volume and speed by which they were coming in. Our healthcare enterprise, very nimble. Yeah. They immediately went to canceling any elective care. Yep. They went to all this stuff to expand beyond what they had truly even planned for themselves. But working back to the EPI group and looking at at that point, where was Paris? Where are they? Okay, where's New York? And where are we? We were looking at a vertical climb 7, really maybe 10 days behind what they saw in Europe. And we're like, we are going to blow through all of our isolation capability, our ICU capability. So that was the time you sat down and the mayor sat down with the governor's office and it's like, okay, we need to build an alternate care facility and we have an infrastructure building in place. We just need to bring the team together and start building quickly. Yeah, and that was, where I think about some of the things that we had to do quickly that we didn't have as much planning for. I do think, our healthcare system in Chicago has been second to none, I would say, in terms of this COVID response. Some of this was because there already, I think, were some good sharing structures, some of which had come out of Ebola. But work on data sharing, work on what do you need, how can we flex, where do we step up? This recognition that as a system, we were going to need to think about this huge surge of patients and recognize that, potentially if what had happened in New York, we had seen here, what that was going to look like. So, it was one of the fastest I've ever seen this kind of work happen, and it remains, absolutely I would make that same decision every time over again. And, that was federal funding that we received to do all of that, and I think learned a lot of lessons, even as we're thinking sort of moving ahead. Okay, so there's some questions coming in about some of the vaccine work, and people are asking. I'll just highlight here quickly, maybe I'll hit a question and then we'll come back to the United Center piece. Becca Wood is asking, are we worried about the Delta variant in Chicago? Do you think it could become the dominant form of COVID for Chicago in the US? And when do we think vaccines will be approved for age 12 and under? So I'll take that first and then maybe we'll talk a little bit about the vaccine piece. So I think, we have absolutely detected the Delta variant. We actually detected it a number of weeks ago here in Chicago. And we have seen cases, not just of the Delta variant, but of every variant that has been detected to date here. And we've seen it multiple times as we've been building up more of our genomic capability. And I do think in the preparedness space, one of the areas that we had not had as much funding for historically was some of that more advanced molecular detection. I think it's an area the U.S. broadly has not had as much infrastructure. So as we've gotten money from the CDC and working with academic partners, we've been able to grow our ability to monitor some of this. So already the Alpha variant, which is the one from the UK, is the predominant one. That is the one that is now here more. And we may see the Delta one become dominant. I think it's possible. The thing with the Delta variant, it is at this point, it is certainly more contagious, and it may be making people sicker. If people have only gotten one of their 2 doses of vaccine, the protection is not very good. The good news is if people have gotten both doses for Pfizer or Moderna, for example, or even the one from J&J, the protection does actually remain quite good about Delta. And so where I think about these variants, as the virus continues to evolve,
if you are not vaccinated, your chance of actually getting COVID, if you're exposed to it, becomes higher, right? Because the virus itself is more contagious. You don't need as much exposure to get sick. But as long as the vaccines remain protective and we continue to make progress there, I don't have major concern. It's more, are we going to see new variants emerge? And so I do worry, and my biggest concern is where we have whole pockets of Chicago that are still not vaccinated. That is where we're seeing cases land. And I think, we don't know for sure when vaccines will be approved for kids under 12. We're estimating probably this fall, somewhere in the September, October range, and we're already doing some planning around that. And so I do think as we are kind of thinking about vaccine, let's talk about vaccine, because where we are now with vaccine is very different from where we were in January. So, can you talk a little bit about the large scale vaccination with this focus maybe on United Center as one example? Yeah. And I know you brought some video to show.
Yeah, absolutely. So going back to planning as a whole, we've always had a plan for how we would do a mass vaccination campaign. 2009 was the first time we as the city had actually executed on that on scale. But when we're thinking about this particular virus and the need to really vaccinate 2.75 million people, we looked at our traditional point of dispensing operations, and we could do this much of the population. We looked at what the healthcare infrastructure and the Walgreens and our private pharmacy sector, how much could they do on this side? And then we looked at, obviously, vaccine availability, and then, we really need to kick it into high gear. Mm-hmm. And that's when we were notified that we were going to be able to take a federal application and build a mass vaccination site with its intent of doing over 6,000 vaccinations a day. Yep. And that's what brought us to the United Center. Yep. I do have a couple of video clips, and they're in time speed, so you're going to see some rapid movement on here. But what we wanted to do is give you a flavor of what it took for our infrastructure teams, our private sector, our union workforce, all the people that were truly out of business, currently not working, to put this United Center together. So right now, this first component is we did 18 plan modifications over a 6-day period of time to see how big and how large can we put in this footprint. United Center, phenomenal host. They gave us full access to the parking lot. So you're seeing construction being built right now, laying out the flooring. What does it look to have a protective floor as opposed to being on concrete or asphalt that's variable, so trip hazards? Working through the infrastructure build. So what does infrastructure mean? When you think of traditional brick and mortar, I'm walking into a building and there's air conditioning and smooth floors and whatnot. We needed to take that into a tent environment. Right. We needed to take that outside. So bringing in the capability for power, bringing in IT infrastructure, bringing in heating and cooling. Mm-hmm. So this building, while it is a tent, was rated for an F1 tornado. So it's surprisingly windy here in Chicago, March, April, and May. So this infrastructure build was set in place to serve truly almost as a brick and mortar institution outside of our normal thought processes. Yeah,
and I think that's another area where, a lot of our planning, and even in H1N1, that flu outbreak, we had been thinking in terms of, spaces that could vaccinate, 2,000 a day, correct, something in that range. Use city colleges, who have been a long-standing, really excellent partner for us. And even in COVID, we've been doing a lot of vaccination out of city colleges and lots of opportunity there. But this need to sort of scale even bigger, and move to really tents and sort of all the pieces that go along with that certainly was something different. Are we still working on that video?
We're ready for
okay, great.
Yeah, so this next part, when we were reaching out to the community, we were trying to get through a whole number of variables. What is your resistance? Is it access? Is it fear of going into a non-medical environment? What were those things? And what our community partners came back to us and said, you know what? A walk-in solution is great, but if I could drive through, I would go to a drive-through solution, just like we did with testing. So the planners sat down, we're like, okay, what does it look like to do a drive-through solution? Now, with this particular vaccine series, there's a wait period after you're vaccinated. So how many vaccinations can we do but still accommodate people in vehicles in a waiting area? And to kind of, the video here is going to show you the magnitude of the site. When we think of the United Center, it's a big stadium.
Right.
But when you think of the parking lots adjoining the United Center, that is a massive footprint. So our first set of videos that you saw was the walk-in solution, and that was rated for 6,000 vaccinations a day on a 10-hour shift. Then on the drive-through side, now you're running through up to 2,000 vehicles through your solution in 10 hours. And a vehicle could have one person needing vaccination, 3 people needing vaccinations, or in some cases we had little minivans that had 10 people from a particular community area or a shelter position that we came in and we were able to vaccinate in one spot. So looking at the flyover, and we should be seeing flyover at this point, just see how big that campus really was and just the sheer volume of the number of vaccinations that we did. So just to give you kind of case in point, as of yesterday, we just went over 301,000 vaccinations on that particular site. So amazing. The other key piece that we learned in planning, but we really needed to put into play here, was setting apart an accessibility capability. Yeah. All of our sites are ADA accessible, but because of the sheer volume of clients that we expected to see, we dedicated one whole tent solution just for those individuals to allow them not to have to navigate through an entire parking lot worth of tent structures, but would come and do restaurant service more or less. I came in, I sat down, I was registered, I went through my screening questions, I was vaccinated, I was observed, and then I left. And then on top of that, language translations. What a phenomenal group of people we had out there. Not only did we have the digital capability, ASL, and some of the other languages, but we had on-site interpretation services. They just rolled over 62,000 translations.
Wow.
62,000 out of 301.
1 in 5 people.
Exactly,
English
1 in 5.
isn't the first language, looking for language
Exactly, and to see an individual's eyes light up that, okay, someone actually speaks my language, can explain the nuances of what's happening, walk with me through the process, not I speak your language, hello, and on your way. Right. It was, here, I'm going to walk you through the solution, explain as we go. Phenomenal experience.
Yeah, absolutely. And I think, where I think about things that we will be doing differently in places where we've grown and where we think about our preparedness, we obviously focus a lot on putting extra resources for people who may need extra assistance, or who don't have the internet capability, or who need additional focus when it comes to languages. But I think the language piece in particular, we'd always translated materials, but I think with COVID we've recognized how much more there is to do in that space. And so I think both for people with disabilities, people who have sort of extra medical needs, and then people with the language access. I mean, and it was interesting, even the language, like the huge variety of languages that came through there was really pretty amazing.
It was amazing. I mean, obviously Chicago, we speak over, 120 languages as a whole. But some of the languages, honestly, I had never heard of before, and yet we had a translator there that was able to speak that language. It was amazing.
Right, and a lot of the, we were talking yesterday, we've historically done a lot of, where we've had written materials, we've gone to like simplified Chinese, but what we actually found in this case, a lot of people coming through with Cantonese, a lot of people with Mandarin, so we've even thought about accessibility as a result of this, and I'm hopeful that as we continue to prepare for whatever's next with COVID or anything else, lots of things about accessibility, I think, are built in and continue to be built in. And I think it's one of the main spaces where we've seen gaps, and we've learned how to work on those, and we continue to work on these as we move ahead. And this week is the last week for the United Center, right?
Correct. So United Center on this Thursday, the 24th, will provide its last vaccination, and then we will be turning the property back over.
Yeah, and again, can't thank the United Center enough, and all of the partners who just, this really central location, it really outperformed my expectations, I think, in terms of people coming from all over the city as one of our fixed pods. And as we're moving away from so many of the large fixed pods. We're not at a point where we're doing thousands a day at these sites. It is becoming much more about this hyper-local kind of work. But yeah, you can still get a free vaccine through the United Center. We've got Pfizer and J&J. The last day for the drive-through is Thursday. Of course, if you're getting your first dose, we'll have to send you for your second dose somewhere else. We'll have availability at Malcolm X, or you can get it on your own. Yeah, it's really been a huge piece, and your program has played a big role in that. So. Thanks. Okay, let's get some more questions in. Becca Wood on Facebook is asking, based on the latest data, which populations are the most and least vaccinated? And are we able to pull up the dashboard real quick? We continue to make just fantastic progress broadly on COVID. We do have a press conference this afternoon at 1, so we'll be talking some more detail about this. But you can see, we're down to just 44 cases a day, 2 deaths a day, positivity rate at 0.6%. Those are, the lowest that we've seen, hospitalizations at the lowest point. And we're doing about 7,400 vaccinations a day right now. And if we want to dig in and see a little more about populations, if I click here on vaccine, for example, you can see that about 63% of all Chicagoans over 12, about 65% of all Chicagoans over 18, and then about 71% of Chicagoans over 65 have gotten the first dose. And then over on the right, you can see the completed vaccine. But if you want to understand what that looks like, you can click right through here. So if you look by age, what you see here is it's actually people in their 50s that are the most vaccinated here in Chicago. About 76% of them have gotten at least a first dose, whereas if we compare that, unfortunately, people in their 80s are still only about 63%, which worries me because those are the people at the highest risk for severe outcomes. And then on the other end of the spectrum, we can see about 54% of those 18 to 29 have gotten a first dose. It's a little better than the national average, but still not where we'd like it to be. And at this point, about 38% of our teenagers, 12 to 17-year-olds, that continues to be the area where we're seeing the quickest growth. There has not been availability there for as long. You can also look by gender here and see we've got more women than men. That's true all over the country too. That's true really every time we have any kind of health-focused, women just tend to be a little more proactive about health. So about 56% of Chicagoans who are women over the age of 12 have gotten that first dose. Or actually, this isn't over the age of 12. This is all Chicagoans, and about 52% of men. And then if we look by race ethnicity, we can see, and this is all ages again, about 62% of Asian Chicagoans, about 60% of white Chicagoans, about 45% of Latinx Chicagoans, about 37% of Black Chicagoans have gotten a first dose, and you can see the comparable completed over here on the right. And we are very much putting the most effort and seeing more progress in Black and Latinx Chicagoans. More than 70% of our first doses last week went to Black and Latinx Chicagoans, but there is still a long way to go here. And where we think about wanting to have the majority of the population protected against COVID, I would like to see all 4 of those really, in the same place. So that continues to be where we put our effort. I would also encourage you, if you're interested, you can look by zip code. There's a lot of different ways to slice and dice this data. You can look at completed vaccine series. You can look at total doses, and I encourage you to explore this for your neighborhood. So good question. All right. Let's see, what else do we have? Let's take some questions quickly here. Jesse on Facebook, I lost my vaccine card. What should I do? That is our #1 question on our frequently asked questions right now. And a couple things. Number 1, you can go back to your provider. So if you got it at your doctor's office, if you got it at your pharmacist, they're not going to give you a new card. Those are held tightly, but they will give you a printout and something that will be valid where you are needing to show your proof. You can also email COVID-19 vaccine at cityofchicago.org. That's COVID-19 vaccine at cityofchicago.org. If you got vaccinated through a City of Chicago site or at the United Center, we will, again, send you a PDF of your proof of vaccination. Or if you got vaccinated somewhere else, it is recorded in the state registry. We will look that up for you and get you those results. And the state is working on the ability for you to be able to securely access your own vaccine record. It's not available just yet, but we're expecting it really probably in the next few weeks so that there won't need to be as much of this manual looking it up. But that's what you should do. Never fear. That vaccine card, of course, is your own proof, but more importantly, in a secure way that is only shared with public health, that record is there and it remains valid for if you need to show proof. Okay. Let's see, Tuti on Twitter is saying, how do I enter the vaccine lottery? I am already vaccinated. Okay, so if people haven't been following this, the vaccine lottery is technically a sweepstakes that the state of Illinois announced, and we're excited about it. You know, there's a lot of push here in Chicago, across the country, toward the 4th of July, right? There's been this national goal set that 70% of adults would have at least a first dose of vaccine by the 4th of July. And realistically, I actually don't think we're probably going to get there as a country. We might, but we're going to get there, but I think it'll be just a little bit later. Here in Illinois, we actually, as a state, have hit that goal. We're still at about 65% where you look at adults here in Chicago, and there's some differences in terms of how federal doses are being counted. That doesn't include people who got vaccinated through the VA. There's some other pieces related to folks who have been vaccinated in other states. So we're actually a little bit higher than that. But nevertheless, we are very focused on really trying to get folks vaccinated, always, but especially as we head toward the beginning of July here. And so the governor announced a lottery where if you have had your first dose of vaccine by the 1st of July, you are automatically entered in this sweepstakes. And there's about $7 million that's going to go to Illinois residents who have gotten at least that first dose of vaccine by the 1st of July. They're going to be doing drawings, I think, starting the 8th of July and moving forward. The $7 million that is cash, I mean, it goes from prizes, I think, from $100,000 to $1 million. Right. That you don't have to do anything to enter except have been vaccinated, and they actually will be looking at that record of vaccinations and then doing a random drawing from within that. For children who are 12 to 17, they're not eligible to be able to win a prize for a cash prize. But I'm actually really excited about this. The state has made available $3 million of college scholarships. So if you've got a 12 to 17-year-old, make sure they've gotten at least that first dose of vaccine. Pfizer remains the one that is approved at this point for kids under 18. So make sure they get that first dose by the 1st of July because, again, there's going to be $3 million of college scholarships. So if you got vaccinated way back at the beginning, December, January, you're entered. If you get vaccinated tomorrow, you're entered. And those remain open to all Illinois residents. But please share that if folks haven't known. So Tootie, you are entered, assuming that you have been vaccinated, and congrats on that. Okay. There's a couple of questions here about kids. So there are questions. There's some people who are saying that the WHO is saying that children should not get the vaccine. No. So broadly around the world, there is still not enough vaccine available for everyone. And what we have seen, we're very lucky here in the US that we have plenty of vaccine available. That is not true in almost any other country around the world. And so countries have continued to prioritize, in most cases, their older residents. And different countries are in different places in terms of which vaccines have had the studies done for children. But here in the US, let me be very, very clear. The vaccine is approved and recommended by the American Academy of Pediatrics, by the CDC, by the Chicago Department of Public Health, by really groups across this country for children in that 12 to 17-year-old group. So there is absolutely, that remains a recommendation, and I would refer you, if you're interested, go directly to those pages, to the CDC, to the WHO, and really make sure you're getting those details directly. Okay. We are already starting to come up on time here. I'll take one more quick one. Anthony Klein on Facebook is asking, can you get a COVID shot and a flu shot at the same time? So, I mean, you want to just chime in on some of what we're thinking there?
Right, exactly. So as we're doing the planning on what will this forthcoming flu season look like, last year we had very minimal flu because we were all doing protective measures. Everyone was geared up. Everyone was
we had
face
one
covered.
ICU admission for influenza last fall and winter. We typically have, hundreds. We have like hundreds of deaths. It's a thing. It was amazing.
Exactly. So the planning team now is looking at basically three components of this. Your back to school catch-up immunizations. What does the flu shot, when will we be able to release that? And then when and if we get the approval to go down to the younger age groups, layering on top of that vaccination campaign. So there's a lot of effort in the background on where can we get the most vaccine out so that you have ample opportunities to do both.
That's right. And specifically on Anthony's question, there was early on when the vaccine was brand new, before we'd done 230 million vaccinations in the U.S., 2.6 billion COVID vaccinations around the world, there was this ask to separate the COVID vaccine by 2 weeks from any other vaccine. That recommendation is no longer in place. So if we do have people, when they come to get their flu shot, who have not yet gotten their COVID vaccine, they will be able to get both of those vaccines at the same time. Children are able to get their COVID vaccine at the same time that they would be getting their adolescent vaccines for back to school, for example. And so you can get them at the same time. And we are doing a lot of planning around our flu campaign and how to link these two together. Just to be very clear, because I'm seeing some follow-up, there is not a booster recommended for this fall at this point. There is no booster because at this point, all three of the COVID vaccines that we have available remain protective against all known variants, and the length of protection continues to look good. So really, at this point, where we're planning kind of flu and COVID, they are not going to be in one shot. It would be two different shots still. But if you already had your COVID vaccine, at this point, there is not a recommendation for another COVID vaccine. But if you've not had your COVID vaccine, we'll want to make sure people are able to get flu and COVID at the same time. Good question. All right, the last one I'll take is Brenda Crespo on Facebook. Says, how does a person who had the COVID vaccine shot, who now has a reaction after being surrounded by people who are not vaccinated or do not wear masks, but could have been vaccinated, I think, what do they do? So there's a couple pieces to that question, and I'm not entirely sure which part you're asking about, Brenda, but let me just be clear. If you've had the COVID vaccine shot, your protection is really, really good against COVID. You got to get both. If you had Pfizer or Moderna, get both. But if you've had both of your vaccines and you're 2 weeks post that shot, or you've had the J&J and you're 2 weeks post that shot, your protection is really very good. So if your chance of both getting COVID and then actually passing COVID on to somebody is really, really diminished. And your best thing, if you're going to be around people who are not vaccinated, the most important thing is that you get vaccinated, because that's your best protection and you're helping indirectly protect those other people. So I hope that helps answer the question. I would also encourage you to talk to people who are around you who maybe are not vaccinated about why you made that decision. And for people who are not vaccinated, we do continue to recommend wearing those masks in public right now. We're making fantastic progress, but we're not done, especially with some of these variants. So we are at time. I want to thank Christopher Shields, our Assistant Commissioner for Public Health Emergency Preparedness at the Chicago Department of Public Health, for coming today. But really, your program has done absolutely amazing work and has tried to make sure at all points we're thinking about what comes next. So where we're thinking about fall, where we're thinking about future pandemics, really trying to be very honest about what has gone well, where do we build on stuff. And when we talk sort of unsung heroes of COVID, this man and his team have been a huge, huge part of Chicago having gotten through as reasonably well as we had. I want to let folks know we will have a 1 o'clock press conference today where we'll be doing a little more about where are we on COVID, looking ahead, and then talking some more about about changes in vaccine operations, vaccine incentives. There's a lot of exciting things happening, so you can tune in for that. And then just one reminder, there's less than a week left for youth to apply to the Mayor's Youth Commission. High school and college-age students, 14 to 19, who are interested in helping advise the Mayor's office, the Chicago Department of Public Health. If you know someone, young person who's interested in this, have them apply. And if you Google it, you'll find it. Those applications are open until June 26th. So we will be back on Thursday for another Facebook. We're probably going to bring this down to once a week, but we're still working on kind of the timing there, and wanting to really have some more conversations about looking ahead and recovery from COVID and pulling in other guests there. So thank you again so much for your time, and thank you for joining us. We'll see you on Thursday.